Hello and welcome to vlog number 3. The focus for this week's blog is to explore what I have seen in my most recent findings across Spain. I'm taking part in the Hope Exchange programme where I'm observing offender healthcare in Spain with a focus on the patient voice and the inclusion of the patient voice in their own care. So today on the blog, as usual, I'm going to look at what I have seen so far. I'm going to look at what's the same. I'm going to look at what's different and any key learning and conclusions around the patient voice that we can take forward in the UK. So let's start with where I have been. So over the last couple of weeks, I've spent some time at the Araba Hospital Network in the Basque Country in Vitoria. I've spent some time at Zabala Prison in Vitoria, also in the Basque Country. And I've also met with the active patient programme taking place in prisons. Okay, so let's start with what I've seen that is similar to here in the UK. So with regards to visiting hospitals and prisons, I can see that the health need over here in Spain is very similar to what we have in the UK, as well as the demographics, and that's the case in both a hospital and prison setting. I've noticed that there are similar security challenges with enabling patients in a prison environment to access healthcare, which is very similar to what we have in the UK. And I've also noticed a clear similarity around the huge challenges that they have here with health need regarding high prevalence rates around hepatitis C and communicable diseases. So there's a big focus on prevention, treatment, but it proves to be an ongoing issue, very similar to in the UK. So what's different, again, from what I've seen this week, a lot is very different. Firstly, a major difference is that you find both men and women in a prison setting under the same roof. Obviously, the model of healthcare has to be adapted to meet the very different needs of two completely different populations. So, for example, in the prison I saw in Araba, there were huge improvements on the mental health facilities for women because that was a really high prevalence rate. But very interesting and not something we experience here in the UK. Another major difference, I've talked about this in previous blogs, is around telemedicine. This is really embedded, again, in another setting that I've visited. 10 years telemedicine has been taking place in this particular prison in Araba amongst various disciplines, and it's having a huge impact on the numbers of patients accessing secondary care services, which for me is fantastic for patient outcomes. Again, another big difference that I've seen this week is the alignment between primary care, hospitals and other clinical settings in a community in the prison as being one healthcare system. So they have shared quality systems, shared campaigns for health promotion and shared staff, and the prison is included in that. So this health system imagines that the prison is just another clinical setting but's part of this same part of the same health ecosystem. So for me, it's just so amazing to see that joined up integrated pathway for the patient. They're going to be accessing healthcare services in their community, potentially from the same doctors in prison and then on release from prison, which is just mind-blowing. Fantastic. Another major advantage of that is that those healthcare ecosystems that I've seen recently have had their own research facilities. So in Araba, they have a health research arm at the Araba hospitals, and the healthcare within a prison setting is included as part of the healthcare research centre. So I'm often involved in doing health needs assessments in offender healthcare, and I know that it's really difficult to find up-to-date research regarding offender healthcare and the population within prisons. So the fact that research is being done on a regular basis around this very vulnerable community and comparing and contrasting with community cohorts, this is a massive advantage. Another big difference that I've noticed is that the health need around patients with substance misuse issues in a prison setting here in Spain appears to be very different from the substance misuse issues that we have in the UK. So an example of that is that the major issue for substance misuse services is that they need to be really, really closely aligned to mental health services, because drug-induced psychosis related to heavy cannabis use is absolutely huge here. I mean, they were talking about, 70-80% of service users accessing substance misuse services have this condition, which is absolutely huge pressure on mental health services. There's absolutely no need around synthetic drugs and MPS, which is obviously continues to be a huge issue in the UK, which really surprised me, those huge differences between two countries which you may regard as being quite similar. Another finding that I've come across in the last couple of weeks is that what's really interesting to see here is within prisons, the healthcare staff here, particularly in the Basque Country, are employed by the local hospital. They're the same staff. So in terms of the management of staff, in terms of the training that staff receive, in terms of equity to care in the community, in terms of the quality of staff, in terms of being able to benchmark community services and hospital services and prison services, you've got the same staff working across multiple settings. Now, that doesn't always happen in the UK. We sometimes have staff who can be quite isolated, working just in a prison setting, which sometimes has its advantages because it's a certain type of role and it's a very specific role. But when we're moving towards looking at equity of access and equity of care, for me it feels really advantageous here in Spain that staff are working across multiple sites, because it seems to benefit the patient. So a final observation that I've noticed in multiple settings over the last few weeks, again, is that real focus on moving towards prevention rather than treatment, and there seems to be a holistic approach to healthcare. So just as an example of that, I'm going to talk a little bit more about the active patient programme, and also from the tele-monitoring that I've seen with regards to patients who have chronic health conditions. And this could be in a prison setting, but it more likely is in a secondary care setting in the hospital. There's increasing use of technologies that I think we could maybe take advantage of more in the UK, where we're proactively monitoring people's health, their vital signs, their blood pressure, their weight, their steps, their food, their smoking, their carbon dioxide on their breath, and that information is being fed back to the hospital with the idea that the more they can prevent health issues becoming more risky and health deteriorating, there is less money and time to be spent on treatment. And it's a really interesting ethos, and it seems to be filtering into the offender healthcare arena here in Spain. And it's just a really interesting observation, and I think that's going to be the future here in the UK moving forward. So continuing on from that theme around prevention rather than treatment, I wanted just to highlight an example and a case study of a piece of work that I've been really impressed by. So I obviously want to talk about some focus on patient engagement, and I think this is a prime example of that within offender healthcare. So I met with the team that run the active patient programme in various settings in the Basque Country, so around San Sebastian. And this is a programme which is based on Albert Bandura's theory of self-efficacy, so that each individual has the ability to succeed in accomplishing a task. It's part of a global health promotion strategy, and it's a specific model that comes out of Stanford University in America, and it can be implemented in various settings and various populations. So it can be implemented for cancer patients, for example, or for a prisoner population, which is what I heard about from the team. Or it can also be implemented and adapted for the gypsy population, for example. The methodology is around group work, and the example that I looked at was all about a group work programme that took place for 2 hours a week in prisons for patients with chronic healthcare conditions, and it's all around self-management. It's all about increasing patient knowledge, motivation, skills and confidence, and that group setting creates a multiplier effect. It's about sharing stories, experiences, and it gives the attendees the ability to think that they can change their behaviours to impact on their health outcomes, and it also gives them a sense of belonging to a group. It's easy to think within offender healthcare that prisoners don't have much control over their own health outcomes because their environment is controlled. But actually what we've seen in the outcomes from this group and the feedback from patients and from the attendees is that the impact of the group has been absolutely phenomenal. So just some examples of outcomes in the prison: there's been an increase in fruit and vegetable intake, reduction in cholesterol and blood pressure, there's been increased exercise, more consumption of dairy products, there's been feedback of increased patient satisfaction, better self-management of illness, there's been kind of reports of taking the drama out of an illness. And it seems like this programme is a really, really powerful tool in tackling inequalities which are really present in the healthcare population. I think this is something really exciting and could be easily adapted to a UK setting, given the right people to drive it forward. And again, it's using that shift to prevention rather than treatment, which is obviously cheaper, more efficient, and actually really empowering the patient and hearing their voice in their own care, which is, again, part of this movement towards empowering the patient. Okay, to conclude, it's been another amazing few weeks of viewing some high-performing health ecosystems, a fabulous prison where the care and the pathways seem to be really integrated between community, between the prison environment, and then on release and resettlement. There seems to be very similar health needs, but the outcomes seem really focused on prevention and early intervention rather than treatment, and the feedback appears to be really positive about achieving really positive outcomes for the patient. So the final blog will be next week, where I'm just going to summarise some of my key findings from this amazing trip, and that will be the end of my programme. Thanks for listening. Bye.